Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much anything else which is infectious at this particular point in time. Welcome to the middle of April. This is April 21st as I record this, a bit later than usual, but I've been spending some time out of town, both at a vaccine congress hosted by the CDC in Denver, negotiating and navigating how to increase both COVID-19 vaccinations and also routine vaccinations in pediatrics across the board. That was earlier this week, and then yesterday had the pleasure and honor of being invited to speak at the Arizona Department of Health Services Vaccine Conference in Phoenix, or Mesa, and there again also being able to speak some good truth to power about the impact and need of vaccines, success stories, and opportunities which lie ahead of us. So already a very fantastic week of talking and thinking vaccine stuff with some, I hope, some positive energy in a forward direction. Going to this week's questions. Again, we have a great collection of those. And the first one is, I think, a very pertinent and important one, and that is, what impact do I think the Biden administration's decision to end the COVID-19 public health emergency will have on efforts to control the spread of the virus? So again, I think just as we all know, the decision had been made, in May to declare an end to the COVID-19 public health emergency, although Congress has sort of pushed a motion to do so even earlier that has been signed by President Biden. So what are the effects of this? Basically, the funds flow, the funds stream for all those free tests to support vaccines for COVID-19, to provide care, and I think especially and importantly for us to prevent any dissolution of Medicaid, Medicare registration. All those go away and will be going away in the very near future. That has, of course, a whole bunch of effects potentially, and again, we can talk about it. The reality may be something completely different. Biggest concern, though, is that there may be a sudden onslaught of patients who are no longer covered by Medicaid, Medicare health insurance, who will need additional coverage. Hopefully we'll be able to do so. Hopefully we'll have insurance coverage programs which are not horribly challenging in terms of providing good coverage and putting them in the poorhouse. There does appear to be protection of pediatrics to a certain extent for funding through CHIP funding, and that would be great, but the reality is that it's going to be a whole new world in terms of insurance providing care and coverage for routine preventative healthcare things. And that, I think, is potentially the biggest impact that might be seen. That said, this issue has been known since even well before the decision to end the declaration of public health emergency, and many steps, including those by National AAP, are already being taken in terms of lobbying, pre-positioning conversations with insurance providers, and even work by insurance providers themselves, thank heavens, to anticipate that this change in need and demand. So that, I think, is a big one. More specific to then the COVID-19 interventions, which will no longer be funded. So not getting all those free tests. I would think that would be a big impact, but the uptake of the free testing recently, meaning over the last 6 months, has pretty much trended down to zero. So I don't know that there's going to be any major impact felt in that regard. And certainly there are plenty now over-the-counter tests which continue to be FDA validated, and those, I think, are being purchased at a typical rate. Not huge, but not zero. So the lack of funding for testing, I think, is not going to make a big difference. The other part of that is, in terms of controlling the spread of virus, it's all well and good to test independently for COVID-19, but if the positive result of that test does not get communicated to the local health department or those who are tracking the numbers, then it doesn't do much good in terms of contact investigation or pandemic control. And that is the unfortunate reality. I think probably all of us have self-tested, and those who've turned positive have not been able to report the positive to the county health department or local health department official, and thus there is no good idea anymore about what the true positive numbers are out there. That has impacts as well in terms of national and global estimates of prevalence of the disease, and as of last March, the fabulous public health data collection site through the Johns Hopkins University just stopped collecting data because it was no longer trustworthy, and also the numbers that had largely sort of plateaued, not zero, There's absolutely still COVID-19 out there, and absolutely patients, including kids, are still being infected, affected, and hospitalized by that. And unfortunately, there are still deaths associated with COVID-19. So I think we just don't know what we don't know, but that has already occurred. And the loss of funding, I don't think will then have any major impact on that. So too with the AAP and its data collection services for pediatric cases. Those all came from shared data from state health departments that increasingly were unable to provide weekly or monthly estimates because they too did not trust their data sources. So not a major impact there. Impact on loss of funding for COVID-19 vaccines. Fortunately, the ACIP, and then by extension CDC, has already included COVID-19 vaccines into the recommended immunization schedule for all pediatric age ranges, obviously for COVID-19 vaccines ages 6 months and up. So that already exists as a strong indicator to insurance providers that the COVID-19 vaccines and the administration costs must be covered by insurance providers. And the initial messaging that has been heard is that that is indeed the case. That insurance providers, whether access related in Arizona, Medicaid, Medicare, etc., or private insurance providers, will continue to provide and cover COVID-19 vaccines. The reality, of course, may be different, but as of right now, it appears that that is the case. Interventions such as the medications, the Paxlovids, etc., that's a decent big deal. And I think it remains to be seen how much or how many of the insurance providers will provide how much coverage for interventions like the antiviral Paxlovid to treat and control patients who are actively infected. The benefit of the drug, the intervention, continues to be important and realized, and the concern of relapses after taking Paxlovid really has paled as one looks at the typical relapse rate in general, and there's not been a significant difference. Also, it has been suggested, and I think supported by outcomes analysis, that those individuals who relapse after taking Paxlovid may have returned to their usual, daily grind of activities far too rapidly because they felt so much better and perhaps are not quite as healed as they perhaps hoped that they were. So the continued use of Paxlovid, I think, remains important, and I don't have a good way to predict anything, messaging or otherwise, how or will that continue to be covered by insurance providers after the end of the public health emergency. So, fabulous question. I think the important and scary things, i.e. loss of insurance coverage, inability to practice normal preventative healthcare delivery in pediatrics, that at least already is being addressed, and I think the early signs are that there should be no significant difference other than a period of change and confusion as patients transition from the current Medicaid, Medicare coverage to some other insurance provider via the Affordable Care Act. So fingers crossed that transition is as smooth as is possible. It's not a question, but of course these questions came out just prior to the very recent FDA and then CDC decisions, so I'll mention them here. I think we are all now aware that as of middle of this week, there was withdrawal of the emergency use authorization for the monovalent COVID-19 vaccines by Moderna and Pfizer, and in its place, extension of emergency use authorization for the bivalent vaccines by Moderna and Pfizer for all indications. So from this date forward, as you're listening to this podcast going forward, all immunizations for COVID-19 that are mRNA based, so that's Moderna or Pfizer's products, should be the bivalent vaccine for all indications from 6 months of age and up. So that means the primary series, if you have Pfizer in the office and a Pfizer bivalent vaccine, it continues to be the 3-dose primary series for infants from 6 months to 4 years. For Moderna, it's the 2-dose series, and we'll get confirmation of any changes in dosing for those. The initial messaging from the manufacturers themselves, Moderna and Pfizer, is that the dosing for the bivalent vaccines will remain the same based on the age. So stay tuned for further confirmation of that, but from this day forward, everything's bivalent vaccine. Yay, fantastic. Okay, moving on to the next question. What is the likelihood of the XBB.1.5 COVID-19 Omicron subvariant becoming the dominant strain in the United States? Guess what? It already is. So that has also been nicknamed the Kraken subvariant. So the XBB.1.5 and also .1.6 are sort of they're very similar in identification. They are yet another mutation of the spike protein. So again, very highly infectious, very highly contagious, but no changes in the virulence and the disease associated with the Kraken subvariant. And so the XBBs.1.5s and .1.6s continue to cause an upper respiratory tract illness, which in pediatrics manifests as potentially very typical URI with the rhinorrhea, the low-grade fevers, the headaches, the fussiness, etc., and also in pediatrics as croup. So COVID croup continues to be a thing, and the response in the treatment of COVID croup is no different from that from the more typical viruses such as parainfluenzas 3 and 1 and some others. As of the last estimate, and this is as of last week, the XBB.1.5/.1.6 account for 82 to 87% of new isolates of COVID-19 in the United States of America. So it's already our dominant strain. Coming up close behind is the Orthrus strain, which is a CBB strain, and that's accounting for 6 to 7% or so. You may also have heard about or read about yet another XBB subvariant, the .1.16, that currently is being seen primarily in the country of India. That is interesting because the .1.16 subvariant is also, in addition to the typical URI stuff, also associated with irritative conjunctivitis. Think pink eye, unfortunately. So those kiddos that you're seeing in your practices, in the urgent cares and EDs, etc., with adenovirus infection may become also due to the XBB.1.16 if and or when it makes a showing here in the United States. So far, only a scattering of reports of that specific subvariant here in the States, but India is one of the countries whose experience we typically follow by weeks to months to half year or so. So I anticipate we'll be seeing potentially an increase in conjunctivitis associated with COVID-19 in pediatrics in the next half year or so. All right, great. Next question. After a recent article reports 2 infants born to COVID-19 infected moms who suffered severe brain damage, what are the potential long-term neurologic effects of COVID-19 infection in infants born to COVID-19 infected moms? Yeah, fabulous question. And the challenge, as we know, is that mothers who are not vaccine protected or who develop active COVID-19 without prior immunologic experience are having severe disease themselves. And that means that the fetuses in utero are being affected either by transplacental infection and or at the very least the maternal immunologic reaction to mom's COVID-19. The overall summative effect of either the primary infection transuterine or the immunologic reaction transplacental is a targeting of a supportive tissue in the brain, and specifically the microglial cells which provide support to neuronal tissue. SARS coronavirus 2, so far as has yet been seen, does not have specific tropism against neurons. Instead, it specifically is going after sort of surrounding epithelial cells, immunologic cells, the microglial cells, which provide support and structure to the central nervous system and causing inflammatory stress to those cells, with then resultant inflammation, swelling, etc., and downstream effects on neuronal processing. So the so-called COVID-19 foggy brain, which is the cognitive defects or affects, I should say, of post-acute COVID-19 syndrome, PACS, long COVID, are thought to be due now to that immunologic disarray within the microglial apparatus, then affecting processing of the brain. That occurs in adults, it occurs in children, absolutely it occurs and will likely continue to occur in those babies born to moms who themselves were actively infected. So I think we can anticipate some significant cognitive burden, including decrease in active learning strategies, decrease in cognition, potentially even children who have overt special needs in terms of neural processing. And the suggestion also is there may be yet another blip or surge in patients experiencing autism, both mild and severe. It all makes sense if you think that the whole thing is immunologically based. So those are the potential effects, and early evidence would suggest that those indeed are being realized. We are starting to see now an increase in severe autism. No other change in environmental factors and infectious factors other than the COVID-19 pandemic. Certainly there continues to be an increase in mild to moderate autism diagnoses, and this may be a combination of getting better at screening for autism, diagnosing it earlier, and also potentially a true increase in numbers of diagnoses that are there potentially related to the COVID-19 pandemic. In terms of infants who are severely cognitively affected in terms of brain damage, hydrocephalus, microcephaly, etc., those numbers are still sporadic. And my understanding as of right now is that it's just too early to tell until babies born to moms during the surges of the pandemic in the last 3 years start to be challenged in higher level education and then found to be wanting. So for right now, at least phenotypically, there's no clear evidence that there's any major surge of babies' overt brain damage after being born to moms with active COVID-19. However, stay tuned over the next 5 years as we start to see those same children start to enter higher level training, education, etc. And then I think we'll see some major impacts. Alrighty, changing gears, and the last question for this week has to do with vector-associated infections. So after the uptick of West Nile virus cases in 2021, do I think Arizona is prepared for an anticipated increase in cases of West Nile virus and other vector-borne diseases as a result of climate change? Very important and timely question, as Maricopa County has recorded its first locally acquired case of dengue virus, which is the Aedes aegypti and Aedes albopictus mosquito vector, the same mosquito which carries chikungunya and Zika. Now we know that mosquito is prevalent throughout most of Arizona, and we know that dengue exists actively right across the border in Sonora, Mexico. So it is truly only a matter of time before we start to see increasing cases of a mosquito-associated dengue at the very least, and yet still potentially Zika and chikungunya, although those are in very low numbers across the border right now. West Nile virus is a different mosquito, and that mosquito also is quite prevalent in Arizona, as are West Nile virus cases, and indeed the last 2 years' worth of West Nile cases were quite significant. So that's sort of the epidemiologic setting. We are at risk. There is definitely already plenty of West Nile virus to go around, and the next question, of course, and what the questioner is asking is, what do we do about it? How prepared are we to deal with these? And I think there are a couple parts that need to go into the answer for this question. The first is vector control. Arizona, like many other states that have mosquitoes, I guess that's everywhere, already has well-practiced outreach mechanisms to try and control the local mosquito burden, to the point where local county health departments are empowered to go and sort of mosquito bomb untended bodies of water, like untreated, untended swimming pools. And in fact, there are caseworkers who are able to walk through the byways and just sort of chuck the mosquito bombs over the fence into those pools. So yay, great, wonderful. There certainly is informational outreach from public service announcements and social media and print media releases encouraging people to look for sources of standing water on their properties and in their neighborhoods and deal with those. So those are all already present. How effective they are, I think you could certainly have some concerns and questions, and it's not for lack of effort. Our public health colleagues are bending themselves over backwards and killing themselves to try and get on top of this. But human beings, unfortunately, don't always do the right thing. Shocker, right? So I think everything that we can do in our local practices, in our local outreach, in our local social media groups to support dealing with mosquito risk is going to be very, 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 very helpful, and of course greatly appreciated by our public health colleagues. So that's the sort of vector control component. I'll leave aside for the moment the very interesting and exciting work of trying to modify the mosquitoes themselves so that they're not able to propagate. This actually in several parts of South America, including actually in Brazil, in Rio de Janeiro, they're releasing irradiated mosquitoes to sort of enter into the population and reduce the population of sexually fertile mosquitoes and thus reduce the total mosquito burden. Parts of Florida attempted to experiment with genetically modified mosquitoes and also infected mosquitoes with an organism which reduced the mosquito's ability to propagate. Of course, everyone think, oh my gosh, genetically modified mosquitoes, now this is the end of the world. And unfortunately, through politics and fear, many of those campaigns failed to gain a toehold. But if and or when we're able to have science break out and reason break out, then there are certainly some very well-tested approaches to reduce mosquito propagation and mosquito numbers. So that's vector control. The other component, however, for an anticipated increase in West Nile virus and other vector-borne diseases is medical and clinical awareness. So we need to be able to accurately and rapidly diagnose patients, adults and children, who may have West Nile virus, who may have Zika, who may have dengue, and other mosquito-associated arboviral infections. Because if we can make that diagnosis rapidly, even if there's not a specific treatment, we can then communicate that diagnosis to to the local county health department that then can go do contact investigation and local case control. And this has happened in my county, at least, and I know in Maricopa County as well, quite actively. So every single case of West Nile virus that's diagnosed is communicated to the local county health department that then sends its control officers to the domestic location of that victim, of that patient, and then does like a surrounding mosquito abatement program to control those specific mosquitoes. The fun thing, I guess, fun is not the right term, but the interesting thing, how about that, is that especially the Aedes mosquitoes, so the vectors for dengue, Zika, chikungunya, are sort of floodplain mosquitoes, and so they will activate once we have the rains, but they also travel no further than 50 meters in their lifespan, meaning they're local gremlins, and thus a local control approach for a designated identified patient with a mosquito-associated infection has great potential to reduce that local spread to other patients in the area. So these are all already in existence, and it's simply a matter of us being aware that there is going to be West Nile virus out there, already are cases, that there are going to be dengue cases out there, and the others as well. If you are not immediately familiar with what any of those viruses look like, certainly CDC and your county health departments, including actually Arizona Department of Health Services, has some really great information on their websites that you're welcome to consult. And if not, please feel free to reach out to me. I'm happy to do a quick little in-service on what those mosquito infections look like. And certainly that's something we can consider doing as an outreach webinar in the near future. So, great questions. Once again, thank you all so much, again, for listening to ID Talk. Arizona AAP members can submit questions for our future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 and other infectious diseases in Arizona, or to learn how to become a member, please visit us at azaap.org. And in the meantime, and as always, keep fighting the good fight, folks. Hang in there. Watch out for the mosquitoes. And fingers crossed that our transition out of our public health emergency for COVID-19 is as smooth as is possible. Be well, everyone.